Hello, everyone, and thank you for tuning in to this episode of the Doc Podcast. Since the show and the audience have grown so much since I launched the podcast in mid-2023, I'm going to start mixing in some of the replays of the earlier episodes of the show so that listeners and viewers who maybe didn't know about the Doc Podcast when some of the earlier episodes were launched can have the opportunity to consume the content. The first of these is going to be the very first guest I had on the Doc Podcast, Dr. Jeff Rothenberg. Jeff is a friend, a colleague, and an amazing orthodontist who practices in Aventura, Florida. Many years ago, well before I launched the Doc platform, I actually taught Jeff my approach to interceptive orthodontic treatment using braces and wires, as well as how to detect the signs and symptoms of sleep-disordered breathing in pediatric patients, and how to coordinate care with his medical colleagues when sleep-disordered breathing is detected. Jeff has since mastered the approach, and we had a great discussion about what it was like to change his philosophy regarding interceptive treatment, how his practice has changed since implementing this new approach, and what it feels like to have such a positive impact on the overall well-being of his younger patients. Jeff also explains how he's taken the approach to the next level by using digital technology to simplify the phase 1 bonding process. So enjoy the show, be sure to share it with your friends and colleagues, and I look forward to seeing you back next week with a new episode of the Doc Podcast. Thanks so much. Hello and welcome to the Doc Podcast. I'm your host, Dr. Mike DeLuke, and it's my mission to help you lead a happier, healthier, and more prosperous life, both personally and professionally. Thank you so much for joining me on this edition of the Doc Podcast. Today's edition is titled Incorporating Life-Changing Interceptive Treatment into Your Practice. Today, I have the pleasure of interviewing my close friend and colleague, Dr. Jeff Rothenberg. Jeff did his undergrad at USF, where he majored in chemistry, went to dental school at Nova Southeastern, and was actually in their inaugural charter class. He did his ortho residency at UConn, and he was a year ahead of me. That's actually where we got to know one another. Had lots of good times and laughs during residency, and we've remained very close friends ever since. Jeff's got an amazing practice in Aventura, Florida, which is his hometown, and he's just truly an amazing orthodontist. I've had the pleasure of visiting his practice, and his patients and staff absolutely adore him. One of the many things I admire about Jeff is that he's always striving to learn and implement new things into his practice in an effort to improve his skills and become a better doc to his patients. And to that point, he's joining me while he's out in California at an interview or at a meeting for Lightforce. So he's hopping on to do this interview and this podcast while he's at the meeting. So I greatly appreciate him taking the time to do that. And maybe we'll talk a little bit more about what his experiences with Lightforce are a little bit later in the episode. So with that, I want to welcome you, Jeff, and thanks so much for joining me on the Doc Podcast.
Yeah, no, of course, this is an honor, and really, we enjoy each other. We enjoy learning from each other and bouncing ideas off each other. So, yeah, any way I can help, yeah, no, this will be fun.
Yeah, I'm looking forward to it. And like you said, we've just, over the years, no matter what, whether good, bad, and different going on with our practices, we've always, whether we just needed an event or had some cool ideas of something we discovered or a product or whatever it might be, we've always just been able to pick up the phone or shoot a text and be on the same wavelength with that. And I think it's helped me. I know it helped me a lot through different times. Like I said, even if it was just to kind of blow off some steam and just chat. So appreciate that and the friendship and you doing this. So before we get too deep into it, let me know if you would just tell me a little bit about kind of your family, your practice. Just give everybody a little bit of an overview of who you are and what your practice is about.
Yeah, so I'm a native to the South Florida area, and fortunately, I practice where I grew up, within a couple miles of where I grew up. I went to school there, lived there, and now I'm practicing there, which I'm very grateful and fortunate to have. I have a family, wife, and two boys in high school, and I cherish them while I got them. Of course, they got one step out the door already. Of course, like we all did. I I basically came back to my hometown. I lived in Florida for forever, and I only left for residency, and I went to Yukon and Connecticut just because it was a special place, special program, and of course I came back, and now I started my own practice for 5 6 years, and then joined into a different practice because I really just saw the potential of doing more, utilizing my mind with more, and the practice is great. It's my team is better than I am, and they make me better than I am, and you're only as good as the people you surround yourself with. And I've always had the concepts of being able to implement different techniques and observing what is effective, what isn't, what does the literature support, and I've been able to do that, and yet I'm still modifying, changing, just to improve, always trying to improve. And so I'm a family guy. I'm outside 100% every single day. I need to be in that sun. I need to be in that heat. And
you inspired me to move to South Florida.
yeah, I never saw that coming. That's for sure.
It was all the texts of you texting me warm weather pictures and pictures of the temperature there when it was 10 below in upstate New York, and it finally broke me down.
Yeah, it broke me down because it was like 75. I was chilled.
Yeah. Tell me you're cool. Now I get it. Now being down here, it's 70. It's like, oh, a little cool today. Definitely different world down here. But yeah, no, I seeing the life you live down here as well, and the lifestyle you had, it definitely did inspire me to be interested in this area as kind of my home for my second half of my career and life. So no, that's great. And I can personally attest to the fact that Jeff's team, I mean, just amazing. Your practice, it's the reputation you have in the community is really cool. And I've seen it firsthand. So, and to that point, the developing and constantly wanting to learn, I think, is one of the things that you were made you able to and open to when we would talk about some of the stuff I was doing with phase one and treating kids earlier. Other colleagues I would talk to about things, especially in my community at meetings and such, they didn't want to hear about it. They didn't want to hear about it. And we'll dive a little deeper into that in a little bit as maybe some of the reasons why our colleagues don't do this. But with you, we would talk about it. And even if it wasn't something you necessarily agreed with or was in your comfort zone, you would question me on it. You would ask me questions. You would ask me to substantiate the things I was telling you I was seeing. And then we'd talk again a month later and you would ask me more questions about it. And you're always looking to step it up and continue to improve what you do. And as I said, to the point that you're out in California now, learning a new technology with Light Force. And I think it's not a coincidence that that's why you ended up trying to implement this approach years ago. And kind of on that note, when I first started talking to you about this, so it's our recollection when we were chatting about this, I think it's probably about 10 years ago that I started to kind of talk to you, maybe a little more, 10, 12 years ago, around 2010-ish maybe, so a little longer, that I started talking about I was expanding patients upper and lower, which coming out of UConn, talking about putting expanders in lower patients, you were like, what are you doing? And so we started chatting about that. And at that time I was using upper and lower expanders, which on the doc website and in my courses, I go into in a little more detail, and actually in some of the previous podcasts as well, like what that looked like. But after doing that for years, so at that point I was explaining it to you, and then we'll talk in a moment about the transition from expanders to braces to do that. But when I first started talking to you about it, going way back, so the first time I said, like, hey, look, I'm putting expanders in upper and lower kids young, and this is what I'm seeing. I mean, what did you think? And kind of talk me through your thought process, and then kind of how you started to implement it and what you saw.
Well, I think the great part of our program, that Connecticut philosophy, was foundation. Understanding the mechanics behind things, and I think we question everything.
Yep.
We were supposed to be skeptical of all of it.
Yep.
But we weren't just supposed to dismiss it before we considered it. Did I think that it was, taboo, if you want to call it that? Sure. It was. I knew of people doing it. It just wasn't ever in my thoughts. Maybe I questioned it, but I didn't say no. I wanted to understand the rationale behind it, and that really should be with all the new aspects and what
Of
does the
course.
literature support and those kind of things. But the approach and the objective made complete sense,
Yep.
and that's what a lot of what we're going to discuss today is. Not just treating the symptoms, but treating the why is it here to begin with. What is the etiology? What is the diagnosis? And that's what you were doing. You were just looking at an approach to gaining space, and we had a background in residency about airway and sleep apnea, and some of our professors went on to preach it for their careers.
hmm
So, and that is, 2001, I was in, 20 plus years. That I would say that's early in what today's discussion is about sleep apnea.
hmm
So you were addressing it from the beginning. I think you were a little off the rocker. Yeah, but I did from when we first met.
I would say
So that's quite all right.
that's par for the course. So, um, yeah, and I think that's a great point about UConn, because so many times people be like, "Oh my God, UConn, they don't teach that." But I say exactly what you said. I said, "Yep, they didn't." And Dr. Nand, if you're watching or you hear this, she's probably like, "What are what are you doing expanding the lower?" But even that, once he saw it, he got it, and he pushed that envelope with his approach. They want Burstone going back. I mean, they wanted us to challenge what we saw, what we were told, and they wanted us to do it from a basis of science and biomechanics, but to push that envelope. And I think as they see this and see what's happening more, they're going to be proud of the way we've evolved our practices, because you can't get stuck practicing one set way, and that's where that UConn mind that both of us developed in our time there made us question things. And I always said that gave me the tools to basically practice how I thought was best for my patients. It didn't teach me a way like, okay, use this bracket and this wire, and it's this formula you use for every patient. It taught us the principles of biomechanics and the fundamentals of the biology of tooth movement. And then when I started seeing what I was seeing with these younger kids, when I got into practice, what tipped me off was when I was first in there, I'm looking going, gosh, there's a lot of crowding, but the teeth, like something's not right. And this was when I first came out, early 2000s. And I didn't really understand. I was in my own practice. I had no one to ask questions. And I didn't really understand why I was seeing what I was seeing, because in residency, one of the disadvantages is you just don't get a lot of 7-8-year-old patients to treat. At least we didn't. And I think I know in a lot of residencies, talking to residents, giving lectures at residency programs, they don't get a lot. It's kind of the norm not to. So I was like, geez, I don't really, I felt so prepared to treat any case from a complexity standpoint that I could face biomechanically with braces. But starting on a young kid, I'm like, okay, do I pull teeth? Do I not? So that's where I started diving deeper into, well, why is it so crowded? And if I'm gonna do this, I think I should figure out why it's crowded before I just start pulling teeth. Well, maybe the teeth aren't the problem, and that was what spurred me on to start to look deeper into it. And then I started researching the concept of expanding the lower arch and so on and so forth. At that time, doing it with expanders, and then what I started to see happen, I'm like, oh my gosh, this is amazing. This is really cool. And that's when I would be talking to you like, dude, I can't believe what I'm seeing happen here. It's really cool. And yes, there's a side effect. A lot of times you don't pull a lot of teeth. Yeah, but I never, I mean, you can tell me I'm wrong, but it wasn't like I called you and I was like, dude, we can stop pulling teeth, or you don't have to pull teeth. I mean, I don't think that's ever, again, that's not the UConn mentality, that it's an always never. It's a, hey, look, when you've got a kid that presents in ABC way, you can look at that a little differently. So when you first started doing that, after we had going back to like expanders, and we'll come to the evolution to the braces side in a moment, what was it like? How was your experience? I mean, obviously I know you can elaborate if you'd like, but putting expanders in 7-8-year-olds isn't always the most fun thing. So talk a little bit about kind of how it went for you when you started doing it with the old way, so to speak, that I was doing it with expanders.
The reason we're doing all this is really for the individual, and it's always an individualized treatment planning concept. So not everybody's going to get that expander or braces
Good point.
or
Yep.
taking out teeth, and that's where we have to differentiate. At the end of the day, what's our responsibility? It's looking at if you're getting adults and they're all broken down already, it's how did they get there to begin with? So here you have these young kids, and you can influence this going forward exponentially. And I find that I would do it strategically, and maybe I would start with the top expander, just initially to have it in the mouth and have that comfort level before I proceeded to the lower. And I take that approach for braces. If I have a really deep bite and I need to, put braces on the bottom teeth, and they're going to occlude on all of them, and now I got to put bite blocks. I mean, that's overwhelming on one visit for, a young child. So I just pick and choose how I do it, and I walk them through it. And when they're successful in it, it's rewarding and it's life-changing for them. So when they come in the next time, it's like, okay, they sit in that chair and they're way more comfortable. Even if it's putting the expander in and saying, don't turn it for the first weekend. You got it on Friday, have it in a couple days, get used to all the food getting stuck in there, and now you're not sore or discomfort, and now you start activating it. So it's a rapid concept. It's going to be accomplished quickly. So yeah, no, it was the kids do better than the parents. I mean, my kids had expanders for their reasons, and it was upper only, and I don't use as many expanders as I used to, that's for sure. But they do better than the parents. And that's our responsibility, to get these children through this experience successfully, hopefully.
I agree. And they're so resilient. I think, looking at some of the reasons, I think a lot about this, and I have this in my courses and podcasts where I hypothesize why I think this is. But I think one of the reasons that our colleagues, shy away from doing this is the intimidation of treating a 7-8-year-old kid. You and I both loved the young kids. The few we saw in residency, we just enjoyed it. And I find a lot of times, I mean, they're easier than the teenagers. They're much easier than the adult patients. I mean, they're so pliable. You can tip them upside down to get, to look in their mouth.
They want to do it.
Yeah.
Come on. They can't wait. I break their hearts when I tell them no.
Yeah. They're just easy and they're fun. And then that being said, what I started to notice is, some kids were, as time went on, kids are getting a little less resilient, and the parents, like you said, it's the parents though. The kids would be fine, but the parents just started being, really making so much drama over these expanders, and it was just, oh, so-and-so, or their brother had them, or this or that, or their friend had them, and they couldn't eat for weeks. And so the kid would get psyched out a little bit. And then there's the other side of expanders, as we know, the food caught, as you said, and the loose bands, and the 445 in the clinic, and kind of all those things that happen, tongue ulcerations and so forth. And so I started about, it was like 2011-ish that I started having some kids who had some special needs and just weren't, I knew I couldn't get expanders on them. I just knew it. And I talked to the parents, and they were like, it won't happen. And they were somewhere on the spectrum, Asperger's. So they're like, but please, doc, don't make me send him to get teeth pulled, because he has to go under general anesthesia. And if we do this, they asked me how many times would teeth have to get pulled. I'm like, 2, maybe 3. We'd have a few sittings if we took him down a serial exopath. And they said, is there anything else you can do? And I said, well, I guess we could try to put some braces on. I don't know if it's going to work, but if it doesn't, okay, great. We take them off and we pull teeth. As long as you're okay with trying it. And we agreed that the patients would be able to sit for braces, and the parents said they could care for the braces. And that's really how it started. I had some patients who were really troubled and emotionally, and they wouldn't have tolerated these expanders. And it broke my heart to be like, well, I'm just going to now basically do the wrong thing on you, essentially send you to treat the symptom instead of the etiology, which I was so against. And sometimes they need a little, oral sedative in the morning and so forth. But the point was, they could tolerate it, and they did great. Oh my God, these kids, they were obsessed with their hygiene. They were so diligent. They were great patients, and man, it worked. And so all of a sudden, you put these full braces on these kids, 7, 8 years old, and they come back 8 weeks later, and you're going, whoa, how did that just happen? I'd been cranking lower expander for 4 or 5 months, once a week, trying to get dental tipping to upright those. And in 8 weeks with a 014, nighttime wire, they're starting to open space, and that's just kind of how it evolved. So I was very careful initially, and I'm going to ask you in a moment, kind of leading you into how you did this. I was very careful initially, and I don't even know if we talked about this at any point back then, to just kind of tread lightly. And I would tell people, I actually put it in my informed consents. I would say, I don't know if this is going to work, but worst case, if it was a kid who could not handle expanders, I would put it in that we would have to pull teeth. If it was a kid who could, I would say we'll have to take the braces off and place expanders. And I started doing it that way just because I didn't want to mislead them, and I didn't want to do something that wasn't going to work. Truth be told, I never once had to add an expander on a kid. I started without it. But when you started it, and then kind of taking it to that transition that I just explained that I went through from using expanders to braces, how did that go after we talked about that? And I was telling you, hey, look, I'm actually not doing this with expanders anymore. What were you thinking when I said that? And then how did that go through in your practice?
Well, first I thought you were off your rocker before.
I remember that one. You're like, what?
Now he's knee deep. He's drowning here. No, again, just listening with a little bit of, my guard up. It's about being predictable, offering a service that's predictable. But I considered it, I listened to it, and, I rack my own brain on the pros and the cons. And so phase one, when we really started our careers 20 years ago, wasn't as prevalent as it is now. And I don't want to say it was taboo, but it involved it's very common now for kids to have 2 phases of treatment. And there were early studies, there were like 3 studies that were really out on, does phase 1 reduce treatment time? Does it reduce extractions and those concepts? And there were great studies. And but still questioning. I would pick and choose, and I would say, okay, this is a developing class 1, and there's crowding, and I don't necessarily need to do anything. The arches are constricted. I'm going to wait and treat in 1 phase. And I did that probably the first 10 years of my career. But then, listening to you, like we've been discussing, it was, why am I going to address this as a teenager if I know it's going to be a problem as a teenager? Why am I not addressing this before it's, a long-term problem? And it's just looking at what is the etiology and what are our objectives. And I'm not waiting for heart disease to then start exercising and eating healthy. I'm going to address it young and early. So I the concerns for me, I would say initially, were root development on max
I remember you asking
laterals,
about that.
specifically. And am I going to damage putting brackets on a developing tooth? That was a consideration. Premature loss of primary teeth, that was a concern, and I'll discuss that. And I would argue that primary teeth, the function of primary teeth is about space maintenance. It's not about eating. I mean, you're going to eat no matter what it is if you have no teeth. So I want to be able to preserve those teeth. Am I going to cause, decay and those issues? So I tried it just the same. I looked at these cases, and the norm and the common thing around the community of orthodontists that I see is upper expanders, and we've discussed this in the past, and 2x4s or 4 anterior brackets, and nothing on the lower arch. So you have 2 constricted arches. And if you really look at the majority of these patients, you look at the lower dentition, it's all rolled to the lingual. It's all narrow and rolled lingually. So now you've expanded the upper arch, and now you have, you're just at the point of a crossbite or a Brody bite, and you're not allowed to expand anymore. You're limited on how much more you can expand. But if I address the lower arch, that gives me more room for both arches to be developed. And when I started addressing it with kids and putting brackets on versus expanders, it's depending on skeletal development and skeletal maturity. And when you really intervene, I think 7 and 8 is different from 10 and 11 or 9 and 10.
Completely.
So the changes were incredible, and the responses were exponentially better. and we're going to dive into that. But the resistance from staff, the resistance from me, not so much. I mean, they looked at me like, now I'm the guy off my rocker. And but the principles of bonding are the same. You're just looking at a different anatomy of a tooth, and that's part of the challenge in learning that. But walking a young kid through this experience and getting them through it, chair side is very similar. Maybe you just have to hold their hand a little bit more. But no, they did fine. I think the bonding technique is very similar, and the experience is very similar. And you're putting braces on. That's what you're doing. I mean,
Yeah,
I don't.
I completely agree. In the courses I built, the CE courses that I built for Doc, the first ones, I went into a lot of the things you just touched on, and the research and the data. And it's funny, you're right. Kind of, it seemed like when we were in residency, early 2000s, Gene Elliott had put out some articles in the 90s and I think it was like 01, really kind of against phase one. And it seemed kind of the prevailing wisdom at that time was really trying to make it about, people just want to charge twice. And that was a lot of what it was. Tun K in Philly, he had one saying that anybody who was saying that phase one was really beneficial, it was quackery. And, again, in my courses, I actually pull the articles and go into it in detail, and not that I want to bore everybody with that part now, but there were a lot of studies out there kind of saying, yeah, maybe this isn't right. And then the study by Bell and some people started to publish saying, well, no, there's another side to this here. And I think some of the resistance is the way we talked about one of them, just people aren't really comfortable treating 7-8-year-olds. And I don't really know why. Like you said, they do great. And in the one course too, I go into a lot of detail on the tell, show, do, and how to, like you said, they need their hand held a little more for sure. You can't just, it's not the cool guy, 14-year-old boy who's going to hop in your chair and act like everything's fine. I mean, they need to be walked through it a little more. But once you follow those steps and understand how that process goes, it is still the same process. You're just doing it a little bit differently for these younger kiddos. And what I never understood was, okay, we learned the fundamentals of occlusion, right? We learned, and this is what you and I talked about way back when you were asking me some really good and hard questions on why I was doing this. And I said, Jeff, look at those lower molars. Look at that lower arch, right? It's caved in. And McNamara has the shoe in the foot concept. If you expand the shoe, the foot has more room. And while in some cases, if you expand the upper, I do see that. And in McNamara's studies, he talks about it. They also admit that it's not really predictable who gets significant lower arch decompensation as a result of expanding the upper. At least I certainly never saw it consistently. I would see one case, I'm like, oh my God, look at their lower, it expanded. And then I look at another case, I'm like you said, you go as wide as you can to get the upper as wide as you can to the lower. And you look at the lower and you're like, I want to get that lower. And I thought it was so funny because a lot of people who kind of shun the idea of going in young and expanding and developing these arches, which incidentally, the concept has been around since the early 1900s. One of the studies like 1913. It's always amazing to me in orthodontics how everything that we do is something that is been thought of or done at some point. But
I'm full circle, sure.
Yeah, completely. And it goes in these sort of peaks and valleys of theory and philosophy. But when I looked at these people, a lot of them put expanded lip bumpers in, or they'll expand their lower holding arch, or they'll expand a TPA, or they'll put a quad helix in or something like that without even or expand a headgear bow, right? As they're expanding. I mean, we learned, get a little expansion into there. So they're fine with that, but you say you're going to put braces on them and do it. And it's like, oh my God, why would you ever do that? That's over treatment. You're doing it twice. So it never made sense to me why, as you alluded to, I would leave this narrow, constricted arch just because it's not something we really do in treating it young in that. I always thought the same thing. I thought, man, and maybe the benefit too of in residency, we didn't get a lot of phase one, but what we did get was a lot of really, really, really severe malocclusions at 12, 13 years old. And because the way it was with us, and I think a lot of residencies are the same, is scoring for state funding purposes. You can't score unless they have a posterior crossbite. They don't count the baby teeth. So these people don't qualify necessarily for to get their services covered. So we would have to essentially, I mean, think about this. We would have to literally, we'd see some of these kids young and we just put on them on observation. And then we'd have to clean it up at 12, 13, 14. And ironically, I think it made us much better orthodontists, because cleaning that up is where you and I would sit there in residency and brainstorm over these cases and figure out ways to be creative and do cool things. But at the same time, if you can stop them from getting to that point, like you said with the heart surgery, the heart disease, it's a great analogy. Why would you not want to be more proactive? And that was the part, like, I never could understand why our profession was, and still a lot of people are, so resistant to being more proactive and not letting these cases deteriorate to the point where you have these long, grueling, comprehensive treatments that don't ever get the most ideal results. So, and we'll come back to kind of the phase 2 that you see happen in the patients that you do this with. So what was your, when you started doing it, how did you start to implement it, putting braces and sort of educating the patients, explaining it to the patients? And we'll get to the airway side in a moment, but just kind of the mechanical side of placing the brackets. When you say to a parent, 7-8-year-old, hey, look, I'm actually going to put your kid in full braces, knowing that probably they've been for 2 other opinions and they certainly didn't hear that. How did that happen? And how did you kind of help your team see that that was something that you were going to be starting to do?
So airway will come into this response. I feel our responsibility isn't necessarily to treat or to tell the parent that this is how we're doing it and this is what you need, because there's more to us just evaluating. I really believe my responsibility as a healthcare provider is to educate the patient or the parent on what I see, why is it here? Why do we have this malocclusion to begin with, and where will it be going forward, whether you treat it or not, and the treatment approaches or objectives on how I can get you there. And by educating the parent, then they understand better of why I see this young child come in. So very common, just as an example, you have a symmetric growth pattern with constricted arches, class 1 occlusion, just really rolled in and really collapsed, and potential change. And right away, I mean, I'll start to discuss some of these aspects where I see all broken down posterior primary teeth, even though there's good occlusion, maybe minimal overbite and overjet at this point,
but crowded anteriorly.
Yeah. Oh, yeah. Well, yes. Sometimes I'll sit there and look and I'll start asking questions, and it's not because I know the answers to the questions, but it's just to bring light to the parent on recognizing, behavior, sleeping patterns, mouth open,
what are some of the questions that you'll ask, that you ask them?
Well, yeah, I'll ask and inquire about, if you ever travel with your child and share a room, do you hear your kids snoring or mouth breathing or grinding? And do you notice where they're hyperactive and they're just restless at sleeping? And it all really goes back to, why do you have this constriction? Well, it's you have look, at the end of the day, there's a genetic component and an environmental component. And the environment really contributes a majority, way more than we ever considered, but I believe it's a majority over the genetic component.
And if you look at skulls from 1,000 years ago, you weren't seeing horribly narrow constricted arches with tremendous anterior crowding. I go into this too in some of my my courses, but
Yeah.
it was diet initially in the Industrial Revolution a few hundred years ago. Soft
Yep.
diets weakened the tongues. The tongue strength didn't have to help in the mastication of the food, so the tongue weakened, and then allergies and airway issues led to obstruction of nasal passageways, lymphoid tissue hypertrophy, and it created this sort of cascade where air couldn't get between the nasal passageways, lymphoid tissue, and then tongue obstruction in the oral pharynx. The air can't get to the lungs going through the nose. So what do?
And the oxygen exchange is different, nose and mouth.
Oh, completely. Oh my gosh, it's night and
And
day.
it becomes underdeveloped when you're not
You
breathing
got
through
it.
your nose.
You got it. Yep.
That book, Breath, is great, and it speaks on the importance of nasal breathing, and it definitely goes into the concepts of how our malocclusions have evolved over time,
Yep.
and how our jaw structure and our skeletal structure, based on diet and evolution and crossbreeding, we have smaller houses for the same size teeth that we did way back then.
Yep.
So,
the etiology of crowding isn't big teeth. Almost, and again, McNamara has a great
correct.
study on that. Indrianti, there's a few good studies. If when people, the article I have coming out in June in Orthotown, we'll talk about touch on some of those. But the etiology of crowding is rarely macrodontia. I mean, it's not that it's never clearly, but it's rarely. And interesting in the book Breath, people in our profession, a lot of them mock it because he's not a doctor and he's a medical journalist. Okay, so he can't report on he can't read literature and data and report on his own experiences.
Stating facts.
Exactly. I mean, I think sometimes we get so caught up in we always have so many letters after our names that we think that people who maybe don't know as much as we do, and I don't think that's the case. I think they don't have obviously the education we have, but that doesn't mean that they necessarily know less about certain things in life. Could Nestor put brackets on a patient and no, of course not. But that's not what he's claiming to do. He's just exposing the fact that if you look at the hard science of what is out there and the literature that's there is a lot to support exactly what you just said. And yeah, it always kind of rubs me wrong when our colleagues, I don't like mocking sources. I disagree, as I just said, the article by Gianelli, some of his articles, and Tung K. I strongly disagree with them, but I don't mock them from where they're coming from, or that they don't have the right to be, say, oh, they're in academia, so they don't know what it's like in private practice. They're brilliant men. I just disagree with their approach to it, and that's okay. And I'm sure they disagree with my approach to everything there. So it's interesting you touch on that. The other interesting thing you said is, and I found that, and I don't even think we ever really talked about this, but I know a lot of people give a very comprehensive airway questionnaire to the patient or parent to the parents in this case ahead of time. And what I found is when I got too deep on that, you lost them. Mom and dad, they're filling this thing out. We know because our forms are online, digital, we can track when they fill them out. Most of these people are filling these things out at 11 o'clock the night before the exam. I mean, they're not filling this thing out, well ahead of time. And you ask them about snoring and mouth breathing. And of course, we do put those in our basic medical history, adenoid or tonsil removal, snore, mouth breathe. But what you said is so important. I found that when I spent the time in the consultation, that couple of minutes, and just asked them questions like that, not just do they snore, but exactly what you just said. When you're in a hotel room together, right? Do you hear Johnny snoring? Or, does his sister in the room next to him ever say that? Or getting to know their situation. And I'm telling you, Jeff, when I started doing that, I would watch these parents' faces and they're like,
they just nod. They start nodding.
Yeah.
Like, yes, they do that. Yes, they do that. Yeah, of course.
Yeah. And then they start to look at you like, how did you know that? And then I start to say, oh, they're a restless sleeper. Yeah. Do they kick the covers off? Like, in the morning, they're upside down in the bed or the cover. Yeah. And they're like out. I can't wake them up. They're like a zombie in the morning, but then they're hyper during the day. Oh, they're a little hyperactive. Anything in school with the hyperactivity? Yeah. Yeah. They're not, reading at grade level anymore. They used to, and you just start to talk to them. And man, I went at a company recently who I should say when I just sent them an email saying, look, I don't appreciate it. They were promoting a consultant who I don't even know what consultant is. I have nothing against her, but the doctorless consultation. And I'm like, man, why do we really want to go there? I mean, Do we really want to remove us from the process? And at that point, if we're doing a doctorless consultation and treating them with clear aligners, whatever you choose, or let's say Light Force or something, right? That's more automated. How far are we at that point? I mean, we're within arm's length of over-the-counter services at that point, right? And you could say, well, you're trained, it's in the background, your TCs are trained to do it. I get it. But there are certain things that we are trained to do in all of our years of school. And one of them is exactly what you just said. That is looking at our patient's records, looking in our patient's mouth, and taking 5 to 10 minutes to just process it and talk to the parents and the patient about it. And if you can't do that in a day, and maybe this isn't the most popular thing to say, maybe people won't like that I say this, but people who know me know I speak what I think, and I don't think that you're doing a service to your patients that way. I feel that maybe in 80% of your patients it's fine, right, and you'll be fine, and it's just a matter of, like, let's say, Mike,
I'd
it's
say
like
maybe 20%. I'd
well,
say it's the small majority.
I agree with you, and people will argue, oh well, if it's 13-year-old with just braces. But how many of your patients, as you just said, are those kids that's just like they're a little crowded? I mean, I
They
didn't
don't
see a lot
exist
of those
anymore.
patients. Yeah, we
No,
don't get
no.
them.
This isn't class one crowding and just changing
No,
colors anymore. No,
no,
that doesn't exist.
we don't
And
get
and,
those
and honestly,
kids.
when I speak to the parents, their usual response is, nobody's ever spoken to me this way and
Yes,
had
yes,
this thorough of a
yes. That's
discussion
exactly it.
about, and now I understand. And how would they understand? I grew up in a family of dentists and orthodontists, and I knew nothing about really the concepts of teeth and malocclusion and
Hmm.
evolution of it and how it, arises, until I went to school and became educated on it.
Yep.
So how can the typical parent that gets no exposure to these concepts ever know it? It's not just about making pretty straight teeth. There's a lot more to this. Let me discuss what's going on and where I see things going, whether we intervene or we don't. And
Yep.
that's really your parental decision. And now you have an educational concept of understanding to make informed decisions and educated decisions. And the response is only exponentially positive.
That's what I was going to say. So what has been your experience after you go through this and you start to uncover these issues? What's the
Yeah,
response?
like you say, little Johnny, it pays attention in class. Like the teacher tells me he doesn't stand at his desk anymore
It's
because
right. Yep.
he's just, and it's, I don't want to get into too much of the overdiagnosed ADHD and hyperactive mindsets, because my one of my kids has just always had energy. I mean, he's
Hmm.
an athlete and he always had energy, and fortunately, one of his teachers let him stand at his desk, and he did better. Um, because that sleep is critical, and the quality sleep is critical, and the oxygen exchange is everything. And here, it's more common to hear people speak of sleep disorder or sleep concerns, and why am I going to wait till it's a problem when I can address it, and eliminate it skeletally, from such a young age. It's like the heart disease. I'm not gonna. So really, you bringing this to light for me was critical in my timing, because at the time I was really, I had a practice that was, I would say, 80% adult malocclusions,
That's
80
right. Yeah, I remember you had a
percent
lot. Well,
adult
yeah, yeah.
patients.
Yep.
And it just happened to be in my career where I got all the complicated cases, the interdisciplinary cases of adults that needed to go into restorative dentistry, full mouth rehabs, pre-prosthetic workups. And so I'm looking at it from a perspective of, how did these people get to this position to begin with? Yeah, I'm going to
Interesting.
align their
Right.
teeth. I'm going
Right.
to set this up for restorative means, and but why can't I address this before it's a problem?
Hmm.
And why is it a problem? What is the etiology of all this? And yeah, maybe you start to create this mindset of, you're looking for what you want to see. But no, I mean, I'm studying in my office, and the prevalence of max deficiencies is different from what it used to be. I'd argue that all day. So it's just all tied together, and it's changed everything about how I do orthodontics. And my phase twos, don't really exist. It's
They're
like
such a slam dunk when you do this in phase
and
one.
and the initial resistance, like you say, was, oh, you want to treat somebody twice, you want to charge them twice. That was common, but it also was, is it saving treatment time, or it's now double the treatment time. And what I educate the parent is, we can wait. Here's where I see your malocclusion, your crowding, your constricted arches, your divergent occlusal plane and growth pattern. And we can plan to take teeth out later. We can plan for growth modification later. You're looking at a 3-year treatment plan with maybe taking out teeth.
Mm-hmm.
Or if I intervene at a young age and I spend 1 year now, specific objectives, I'm not accomplishing the world, I'm not changing everything, but 1 year of developing arches, then my phase 2, when you have all your adult teeth, is it even needed? Not always.
Not always.
But not always. The teeth have their parking place and they know where to erupt.
Yep.
And okay, the rotations. So yes, there warrants a phase 2. What is that phase 2 as a teenager? 12, 14 months? That's your class 1 crowded case.
Completely. Right. Or if you get the one that you knew was retrognathic in phase 1, pre-phase 1, I'll explain to them, look, Johnny is a 2-phase kid. Like we are going to, things are going to look great. We're going to make room for the teeth, but he has a small lower jaw and we can't do much about that till he's closer to his pubertal growth spurt. So he's going to need me to go in later and he's going to have, more than the typical 10, 12 month second phase. He's just one of those kids who needs 2 rounds. It's just, a lot of times the parents are like, oh, that's him with everything, right? He's the problem child.
Right,
parents get, but people get that certain kids are different. And it's such a great point you make. It's how you explain it and educate it to the parent. And if your mindset is, and I think actually if I take that a step back further, I think the reason why as orthodontists we tend to put up such a wall and barrier with this is even when I know for sure when I was doing headgear and lip bumper at the very beginning of my practice, I wasn't making phase 2 a heck of a lot easier. When I did upper and lower expanders, turnkey, Hyrax type, it made it a little easier, but I really didn't see that many patients that I either eliminated phase 2 or really made it kind of a slam dunk, quick, easy 10, 12 month. Because when you're expanding those arches, as we all know, you get over expansion, the 6s, the 7s come in. There's just a lot of things. The arches aren't coordinated. I think it's D'Souza, one of his articles that talks about the arch deformation that happens if you don't address the incisors and arch form, if you just expand. We've all seen that. So if you have these patients that you're doing this phase 1 on, and you're doing a lot of heavy lifting, right? Things like headgear, lip bumper, expanders, and you don't get a real reduction in phase 2, I can see where people are going to, our colleagues and the public are going to say, what the heck is this phase 1 thing all about? I'm wasting my time and money. I can do without it. Once I put these kids in full braces and I saw, holy cow. And the arch is what I determined too, and I'm interested to hear, I think we've spoken specifically about this indirectly maybe, is the arch form that we get with, expander, you have this narrow V, you get this wide V still, right? And how many cases did you see where you put an expander, and let's even say someone who doesn't believe in any real arch development in phase 1, but they just treated someone with a unilateral or bilateral posterior crossbite with an RPE, right? You go in, you expand, you end up with this wide V, and the canines are impacted still, right? And you end up not enough room for those canines. You're sweating every time they come in for a follow-up progress radiograph in retention. Where are those canines? Are they going to come down? Now you got to tell the parents, I got to pull up or buys maybe and exposures. And they're like, why did we do phase 1? I thought that would solve this, so forth. I can't think of a case, unless it was just like a genetically, say, horizontal canine that was just never going to turn and come down. My incidence of canine impaction for a patient I did phase 1 on, obviously I saw it still with people who never came in for a first phase, I think it literally almost went away. I mean, it just, because you're getting the space where you need it, the anterior middle thirds of the arch, when you're using the braces versus expanders, and you're not over expanding and blowing them out posteriorly, which has negative effects. I would get some of these kids, I'd be trying to get the space anteriorly and get them wide enough to get the arch right. And again, not space just because I didn't want to pull teeth, but space because that's where the etiology was. I was trying to fix the etiology. I couldn't get it. And you keep creeping that expander out. And now these kids start looking disfigured at 8 years old. And you're getting these, wide nose starts to bridge of the nose changes, and you're getting the parents like they look too wide. And so when I went to braces, that just went away. And I was like, I can't believe this. And back to your initial point of phase 2, I mean, it's slam dunk. And the phase one retention, it retains its, I mean, I use upper and lower Essex C plus. And I do full-time 3 months, nights only. And after that, you just cut them out chair side. They're really easy to adjust. But the equilibrium you create, which is what you were saying with because the tongue can come forward and sit forward, and they'll kind of transition this into the airway changes you've seen. It maintains itself and elevates, right, and keeps the shape of that palate. It maintains itself so beautifully. I used to see RPE cases that would kind of collapse a little bit, and you'd get that high vaulted palate would come back. Well, I think it was because, looking at it critically, I didn't make enough room anteriorly for the tongue. I made a ton in the back, right? But in the front, I never developed the anterior enough. And so that tongue never could really come and sit forward and superior. And the tongue would then, when I took the expander out, settle back. And I used Hawleys at that point for them. And kids hated Hawleys. And as teeth start to fall out, they stop wearing them because they don't fit anymore. And so I would get relapse. Now, if I have a kid that stops wearing the retainers, you might see the incisors a little bit move, but literally the transverse is rock solid. It just doesn't go back. And if it does, it's like, let's say you have a 2 millimeter change or something, and in phase two, it's an absolute piece of cake to just, to touch it up if they need it. So it's really interesting. So on that note, tell me about your airway evaluation in terms of like how you work with your ENT and allergist, or how you work with your medical colleagues when you see certain problems. Because one of the things I want to make clear to people is, I know you don't, and I certainly don't, and never did, go out and tell people, oh, put braces on kids at 7 and everyone will breathe better. I mean, that's insane. And it's certainly not even close to what either of us are saying or ever did. It's about, again, the etiology. And if they are narrow and have a transverse discrepancy, and you see it as the symptom of anterior significant crowding, and you develop the arch and make more room for the tongue, you can, and change the shape of the roof of the mouth, you can improve the airway. That being said, a lot of people say, oh, you need to send these kids for sleep studies. And my attitude was a couple things. Number one, how easy is it for the average working parent, maybe single parent, with X number of kids, to take this kid and them, go sleep overnight in a sleep lab and hook this kid up to dozens of electrodes, right? Practically. And what are you going to gain from it? They just told me he's snoring. They just told me he's a mouth breather, and I can see that he's got crowding. So why not address the intraoral problem? And if I need to have my ENT or allergy colleagues involved for the lymphoid tissue and or nasal passageways, let's do that. But I'm not about making it like, let's diagnose them with sleep apnea. No, they have sleep disordered breathing. It's clear, because once you snore and mouth breathe, you have sleep disordered breathing by definition. So we know that's the case. Mom just told me, right? Why don't we just address it that way? So talk me through, and I don't know if we ever specifically spoken on those details of how we approach that. So I'd like to hear your thoughts on kind of when you detect those issues, how much looking at the airway on radiographs, and actually another good point, to my knowledge, you don't use cone beam, right? You use a lot of people think you need to have a cone beam to be able to see and detect and uncover these airway problems. You don't. And I'll let you explain how you do it, and how you figure that out, and how you discuss that with the patient and their family.
Right. I'm not necessarily needing that sleep study to diagnose sleep apnea. That's not necessarily what I'm trying to do, but I can readily, just with our standard way of taking records, diagnose sleep disorder or airway concern,
right?
And
exactly.
And still educating the parents on my professional opinion on my evaluation of these concerns, and
exactly.
And then I elaborate in it, and I look at the Ceph, and I start to explain to them, the upper airway, and as you breathe through your nose, this is where you have obstruction or potential obstruction, and they say, oh yeah, I've been told I have deviated septum. I would argue we all have a little bit of a deviated septum, but what about the size of the adenoids? And then your lower airway, and looking at the size of your tonsils and the influence of these things. And what I tend to explain is that when I was a kid, people had tonsils and adenoids removed when you were sick all the time. It was kind of that time period, and that's when what was going on. And then they really stopped for a long time. and they weren't really addressing it as much. And
Yep.
and that's where big pharma and medicine came in, and steroids and nasal sprays,
Yep.
and there's a place for it. And what I kind of speak to the parents about is, okay, if you have this obstruction, you can take medicine for it for 3 months and then stop, or chances are years until adenoids really reduce into the teenage years, or you can consider removing the obstruction entirely.
Mm-hmm.
But that's not for me to make that decision.
Exactly.
We're a team, and I got my team within my office that is critical, just like potential an evaluation of an ENT to say, okay, your adenoids truly are enlarged, and it's something to consider. But it doesn't all come from one place. We don't correct class 2 malocclusions all from growing the mandible. I mean, it's a little here and a little there, and orthodontics has a critical role in that as one of the facilitators. And if I witnessed it, that when I intervene with these kids at the right time for the right patient, then growth and behavior and breathing and all of that change radically. So is it wrong? Someone, and I get, that resistance. I get the resistance from ENTs. I get resistance from parents, and I get calls from dentists that say, why are you doing this? Like, are other people doing this? And I'm no pioneer, but someone had to be the tip of the spear.
Yeah, there's some clown that was in upstate New York doing it.
I mean, right. That's right. I know this one clown, but truthfully, we understand the principles, and our objectives are being addressed, and we're being successful. Then how can you still naysay it or dismiss it before you've even listened to it or considered it?
Yep.
And shame on me to say this in San Diego. I mean, I joke that we're trying to change the Navy here, and an old way of doing things. And I understand that concept and that reservation, but sit down, listen with just an open mindset. I'm not trying to preach my politics to you. I'm just trying to explain the rationale of what I see. And so I do think an ENT and a primary care is part of the team, and I leave that to the responsibility of the parent. But I speak to them and send my letters of these are my observations, these are my opinions, these are my recommendations, and I address it the way I know how to address it, and it's orthodontically. That's what we do. Right.
Like, I'm not doing it because I'm diagnosing them with sleep apnea, so I'm expanding them like that. That's not what it is. No, I took a thorough history. I realized they have these sleep issues, but my priority, as you said, is the orthodontics. Conversely, I'm not going in on kids with broad arches and sleeping disorders, of which you almost see none, ironically, or not ironically, as the case might be. But when's the last kid you saw with these big, broad horseshoe arches come in that had these same sleeping issues?
I'm sure you sleep like a baby.
Yeah, exactly. Well, I've got the nasal passage.
You got the nasals.
Yeah. From an arch form perspective, I'm good. But that actually, to that point, that's the complexity of it, where every patient and taking the time to look at every patient is so important. And when you see that kid that's really broad, and I can't help, right? Like, I mean, let's say they're 8 years old, class 1, good spacing, broad arches. I don't tell them if I put braces on them and expand their arches, I'm going to improve their snoring, because that is not a me thing. And I can't improve their intraoral environment anymore. That's the kid I would say, you need a sleep study. You need to go talk to your pediatrician and an allergist and or ENT, because they need to figure out why Johnny doesn't breathe well through his nose, because I can tell you it's not because of his mouth. And it's not because of his tongue, unless he's macroglossia or something, as like a huge tongue, which again, not that we can treat, but we can certainly diagnose and help with that. But you almost never see those patients. And that's what I say to people too. And I think we get caught in these always nevers. And you touched on something there, which in the article in OrthoTown, that the CE article, part 1, that's coming out in June, that I talk about the paradigm shift. And that shift is a mentality shift, right? It's not a shift in treatment. I mean, use braces to develop arches in phase 1. Well, we've used braces for a very, very long time. So it's not that it's like a paradigm shift, like, we're doing something in the profession that has never been done before. Like say clear aligners, right? They were a paradigm shift from a clinical perspective. This is a conceptual paradigm shift. This is treating the etiology, as you exactly said, right? This is not looking at it as a symptom-driven approach where that kid comes in at 7, 8. What do most of our colleagues do? And I'm not being critical. We did it too. We pushed ourselves to evolve differently from a mental standpoint. You say, how much crowding is it? Am I going to need to pull teeth, right? Can I do this with space maintenance? Can I get them in that early mixed dentition, as Janelle used to talk about? And he used to talk about, I can basically save most people from extraction if you start treating them in that mid to late mixed dentition. Again, that to me is symptom driven. You're just focused on how you're going to deal with the crowding of the teeth. We're talking about something very different, which is, why are the teeth crowded?
Mm-hmm.
Why are they crowded? Why does this kid look like this? We
it's
know
everything.
Right. And we know it's almost certainly not genetics. Because a lot of times too, these parents will be like, yeah, I had some braces, but I didn't have his problems. And dad had, didn't even have anything. And you look at Johnny and the arch is like this, and he's, and you've got the thick gingiva and the chapped lips. And do we really want to make that discussion about whether we need to pull teeth? Like, that to me is so secondary in this.
It's the last thing you want to do. It's the last thing you want to do is take teeth out and further constrict the arches and destroy little Johnny.
Right.
And the hypertrophy of the gums isn't because he doesn't brush his teeth. How many times can you tell the kid brush his teeth? It's because the environment in his mouth is different. It's because his mouth is open all the time, and therefore the architecture of the gums is different. There's no inflammation. It's hypertrophy.
Good point. Yeah.
There's very big difference.
Yeah.
And the paradigm shift, it is finally happening, and I'm thrilled that we're living in that concept and time for orthodontics and in medicine. And Peter Attia speaks about longevity, and he speaks about why are you going to wait to exercise and eat healthy when you already have diabetes? No, you're going to address it and at a young age, and the earlier the better, and you won't end up with these kind of ailments. And that's our responsibility. We're seeing kids younger and younger, and we help them on this journey, and we don't have the big problems later because we've addressed the true etiology of what's going on. And so, yeah, it's great to be part of this shift because it's effective, and I would do it for my kids, and that's how I look at everybody. If you're my brother or you're my family, I'd recommend the same thing. Or at least I'd educate you the same way. And if my brother doesn't listen, then that's their parental decision.
Of course.
My brother never listens. It's okay.
But it's any different. It's so true. And I think that's one of the things you and I have had in common from the very beginning. And we talked about this, I'm going back to UConn days, was we look at everybody like they're a family from our patients. How would I treat my own family member? And I think if people kind of from a moral compass, not to get all, like we're so ethical, but it's just a general statement. If you look at every patient and treat every patient like they're a family member in terms of how you approach their case and what you try to do for them, I always felt that I took that responsibility of my patients and doing right by them very seriously. And when you do, and you've told me some of these stories, but elaborate on some of the feedback after you've changed these kids' lives that happened to you in your practice. Just pick a story or two of some of the things that happened when you started treating kids this way.
Yeah, just the kids, they don't know the difference too much unless they don't look right. If they have that psychosocial aspect of it, and it's real rewarding.
Which is another side, by the way, that I found is just awesome.
Yeah.
How much these kids just love how they look after. But anyway, so go ahead.
No, but some of the like I've had some of the moms say, just everything from the first time they met me and they listened to what I had to say and they considered it and checked off the box of, yes, my kid has this and airway and mouth breathing and all these things. And then they got to witness it on their child of how everything's changed for them. They've had me come to speak to their mom groups. Because you never get this information unless you seek it yourself. I mean, now with the internet, you can find information and listen to podcasts like this and start to be informed. But unless you fall into that office, how are you going to know? So here was an opportunity for a group of mothers or parents, because there were fathers, and to just listen to the philosophy. They wanted to hear the philosophy of why I treat kids at a young age, and why some of their kids' friends had expanders or braces on the front. What do you mean? You put braces everywhere? I see kids with just braces on the forefront teeth. Well, kind of you touched on, if you just expand and you still have this expanded V-shaped arch, then you've never addressed the anterior. Well, 4 anterior brackets doesn't address the curvature of the arch.
Nope.
It's and I'm not trying to
makes a nice
justify my
flat front, you know. It makes a nice flat front on a front of a big V.
It's a fence. It's a fence. I'll never put 4 brackets alone. It just so again, I just think about what I'm trying to achieve.
That's exactly what I've been finding, is that parents just they are frustrated that no one else is doing this, because they have friends and other family, cousins that go to other practices in that area or other areas, and like, why is no one else doing this?
And not everybody agrees. And I tell people, I'm not trying to convince you of anything. I'm just trying to allow you to see it from my perspective, allow you to understand the concerns I have long term, and get into my brain so you understand my rationale for my decision making. And it's like 10 times out of 10 that it's a positive response, and grateful responses.
And I had parents literally in the consult, when I started talking to this way, figuring this out about their kid. I've had moms break down in tears. I've had moms who literally started not bawling, crying, but tearing up, going, I knew it. I knew it. I've been telling the pediatrician, or I knew something was wrong with him. I knew. You know, moms know, they have such intuition. Dads, well, sometimes we know, but we don't
have to land on our lap.
It's gotta be a little more obvious for us. But moms have this maternal instinct, and they know when something's not right with their kid, and they may even not know it consciously. But I've had multiple moms, and at the end, I've had moms just like, and dads, truthfully, I have actually some video of both, just being like, this is crazy what happened to this kid. Like, this is crazy what happened. Do you find that those people become ambassadors of your practice? Do they refer other people? How did
Definitely. Definitely.
So do people start to come in, now that you've been doing it for a bunch of years? Do people call asking for this? Do they come in and say, you know, kind of, what do you see from that side?
I think it's the best form of marketing from every level, because here you're helping individuals, and that's how an authentic way of growing a practice. And I'm not a big marketer, because I'm not trying to sell anything.
Same. I never was.
I'm just trying to inform and provide and care. And yes, they're the best kind of referrals, and the best kind of patients that you want to be a part of their kids' lives. And you get to see them grow up into confident individuals. It's so yes, I mean, regularly, that's how, you know, the word of mouth growth is what I see, for sure.
Yeah, it almost precedes itself. I found I had to do much less explaining of this. It takes years. And there were people early on that actually would tell me, no, we're going with the other opinion because they use expanders, and our dentist said that's been around longer. And that happened to me initially. And it wasn't often, but it happened. But I'll tell you, after like 4 or 5 years of doing it, you know, we'd get calls from people from all over, like, we want the guy who does this without expanders. And I certainly didn't do it for that reason, but I think it's important for our colleagues to know that once you start doing this, you get a reputation in your community as somebody not only who does something others aren't doing, but as a thinker. And as people had so much more respect for me as a diagnostician. You know, I think people had a lot of respect for my clinical ability, even prior to me getting a reputation, going in, doing this young. But as I started seeing within the general dentist, pediatric dentist community, a lot more referrals, people would come in saying, like, you can figure things out, others can't. And it wasn't really necessarily that the others can't do it. It's just I was willing to look at it a little differently. Like anyone who's gone through the schooling we've gone through is capable of figuring out what you and I are talking about right here.
The majority of those orthodontists are more intelligent than me alone.
I mean, I wouldn't put my IQ up against theirs. I agree. You know, I
just listened. I listened to what you were having to say without just dismissing it. And I'm thankful that I did. It's been a game changer and a life changer for me professionally
That's
and
awesome.
personally. So
I appreciate that. And on that note, the next sort of change here you're going through, which I didn't have any experience with. I don't know. I had finished up my clinical practice within the past year. So Lightforce is a newer product that you've been using, and now it's time for you to kind of teach me. I mean, you've told me some really cool things about what it's done in your phase one approach. So again, in my online the courses, I teach people how to put the brackets on the primary teeth because there's a learning curve. You and I spend a lot of time on the phone. Kind of, I would give you the strategies on where to place them, and I go into that in my courses because if you just throw them on teeth blindly on the primary teeth, bracket's going to come off. You're going to have a lot of breakage. You're going to interference occlusally and so forth. But you took it a step further, which again, as I said, I love about how you approach things. You're always trying to get one step better, and you started doing this for with Lightforce. So talk to me a little bit about how that's taken it even a step further on these phase one braces patients.
Yeah, and I'm not speaking for Lightforce. I'm just speaking of a method of how I practice.
Yes, and I have no financial ties, anything at all to Lightforce in any way. So thank you for mentioning that.
So some of the early challenges that I really had with putting brackets on primary teeth was the anatomy of the primary first and second molars. The rest of it was pretty much the same. Bonding is bonding, and the dentition anatomy is very similar. But the primary first and second molars is very different. And the traditional way of brackets for the last 30 plus years is a concept based on averages of tooth size. So you would have a pad that fits all teeth. Well, it was never really designed to fit primary teeth. Right. So here we're bonding to really big convex anatomy, and you would have breakage. So there's strategy to where to place that bracket, and it works. I mean, I do it all the time. But now with customization, and that's what Lightforce is. Lightforce is a way to print and design your bracket to the actual need of that patient specifically. So no other human on earth has that exact bracket design because the pad is printed to the exact anatomy of the tooth. So here I just, okay, custom brackets. I wasn't totally interested, but I was willing to listen to what it was about and how I can apply it, so I listened. And what I started to think about is, okay, now I can have a pad that is the exact anatomy of the primary first and second molars. And exponentially just bonding is a joke.
Makes sense.
And it bonds perfectly every time, better than I could place it. But more so to that is I can be really strategic on how to address my objectives. So if I'm treating a 7-8-year-old because of real constricted arches and trying to create this dental alveolar arch form, well, I can, so very common on the lower arch, everything's rolled lingually. Well, now I can design the bracket to have more torque and uprighting in the posterior in the bracket design. It's huge. Just putting the wire to do it expands in a traditional bracket, but it still keeps the teeth rolled lingually because it's that kind of prescription. So here, and you can say, oh, give me the Roth or MVT or whatever you want. Now you have just here, most orthodontists have one system, maybe a couple systems in their practice. I have more because I believe in everybody is that individual. And with Lightforce, I don't hold that inventory. I create it individually. So
I used to have a separate set of braces for my comprehensive, adult permanent dentition cases and my phase one cases. I had two totally different, they're actually different manufacturers for my braces because I had to build a prescription custom for my phase one. And I keep referencing that I do explain this in my course, but it's a lot of work. And I had to, the reps are like, well, we don't really have that, but I can give you this angulation and this tip. And there's a lot of heavy lifting there, number one. And then you have to track different bracket systems. What you're saying with Lightforce is, as you've explained it to me, that just sounds so much simpler for that.
It is such an incredible concept to be that strategic and that specific, that, off the charts efficiency, chair time, treatment time, visit time. I mean, that's studied, and you can naysay it because, oh, what do I need a custom bracket for? I've been doing it this way for my whole career and traditional brackets. Okay, who uses roll-up windows? I mean, I love vintage. I'm all about an old vintage Bronco, sure, but I love my electric windows, and I love the efficiency and technology of being custom to what I want to achieve, and that is the principles of light force, and how I can apply it to the challenges in primary dentition is exactly where it's at for me. And how I'm using it, and more, I've started slow in that I was using it just for specific cases, and now just more and more, I'm gonna bring it into and kids still want metal braces and they want the colors, and I tell them, put the colors on the light force. It's only clear, and you see that color pop. I mean, it's gorgeous, but the color and the prettiness and aesthetics is not my objective. It's how can I be more effective and successful, and this is how one of the ways I do it. Big armamentarium.
No, that's great. I love learning about this stuff too, and it sounds like that's because it is a learning curve when you start placing these brackets on baby teeth. It's I think back to it, and it's like, oh no, I mean, I got so good at it and so efficient, just like anything we do as orthodontists, that you kind of forget the pain you went through to figure out how you got there. But there were some pain points, for sure along the way. I kind of developed a bunch of hacks to figure out how to bypass it. But if you don't have to do that and physically do that chair side, and you can do it digitally, proactively, again, the proactive approach versus the reactive, it makes complete sense. So I appreciate it.
And the procedure of the chair time, I mean, just so you're not sitting there placing brackets. So Light Force is an indirect bonding system, versus traditional placement of brackets. So the chair time for the kid is start to finish, you do an arch in no time. I mean, it's insane, and the jigs are off the charts accurate. Like, I'm actually studying that. I'm just curious myself on the accuracy of these jigs and the placement of that bracket. So if there's a learning curve in anything we do, of course, and but if you're trying to meet an objective of chair time or comfort, or getting a child through an experience, here's another way of doing it. And I have less chair time. And less debonds and less repos. So that is how I implement it. And I'm thrilled with it. And that's why I'm in this meeting, because I just want to learn more about it. Get better at it.
Well, that's great. I appreciate you sharing that, because I like to continue to learn, and it helps me to see and be able to help other docs that take my coaching or courses ask questions about this stuff. And again, no financial ties at all. Just I love great companies that do great things with innovative, great products. And if it's something that can help the patients or the doctors doing it, and both, and then I'm all for it. So that's cool. So, but well, I thank you. I know it's bright and early out there in the morning before your meeting, so you got to get shoving off to get to the meeting on time. But I don't know if but you were really instrumental in me kind of going and taking this leap to teach. And we've never really specifically talked about this, but there was a time I remember I was in the car, and it was after I'd made the decision to slow down my private practice and go into teaching. And I was starting to get kind of like, well, I think I could teach in some different areas. I could do some stuff on herps and Invisalign and different things, and even get into some of the financial stuff of how I was able to retire the age I did. And I remember you saying, you're like, you need to get the phase 1 stuff out there. You're like, that's your calling. That's what, you explained. That's when I really started to realize how much it changed your practice and how much it had an impact on you. And like, you just need to get it out there. This changes kids' lives. And I can literally picture where I was on the road when you said it. Because I was starting to just think, well, maybe I don't want to go all in on that. So what I decided to do is basically build Doc, Duluth Orthodontic Coaching, to be something that will eventually get even more comprehensive, but make the initial focus, which if people go online and look at a lot of the course content, early podcasts, a lot of it is actually almost all of it is on this. I didn't even get into you with the cleft craniofacial population and how this works with them. It is just unreal. There is a course on the Doc website about that. I'll be having a craniofacial surgeon on, ENT, to talk about that more on the podcast. But it spoke to me, so I appreciate you kind of giving me a little kick in the backside to be like, no, like if you're stopping practice to go teach this, you need to focus on this side of it. And I remembered that, and I went all in on building the systems to make this the case. So I appreciate that, and appreciate your friendship and our collegiate interactions that we've had over the years. Someone I always enjoy talking to, and not just in this forum on a podcast, but about all things in life. We kind of share a vision and a philosophy in a lot of ways, and it's just kind of transcended even what we do clinically and professionally. So but I appreciate you taking the time to share this stuff. Because it's just not something that our colleagues are hearing a lot of, and I can sit here and talk about it all day, but hearing it from someone who learned it and then went and implemented it and what it did for you in your practice, I just think is really, really helpful for docs out there who might be thinking about this and not knowing what the next step is. So I really appreciate it.
Yeah, right back at you. Really, you've helped me be better, and really we're in this for healthcare, so you've helped more patients have better results, and that's and with no ulterior motive, but just to provide the best quality healthcare we can.
Mm-hmm.
So yeah, our friendship is way more than just professional, and this is an honor, and I'm happy to speak about it, and I thank you. Really
cool.
Appreciate it.
Same here. So, well, thanks so much. Enjoy, have fun out there in Cali at the Light Force meeting. Learn lots, and we'll talk soon.
All right.
Take
care, Mike.
All right.
Appreciate it.
Thank you too. Thank you for watching this episode of the Doc Podcast. Be sure to visit theorthocoach.com to get access to ADA CERP recognized CE courses, or to schedule a private one-on-one coaching session with me. And remember to join the Doc community on Facebook for more great content designed to help you succeed both personally and professionally. Just go to Facebook, search for the Doc community, and request admission into the group. You can also find Doc on Instagram at @theorthocoach. And always remember, you have been blessed with the ability to do amazing things.